Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert. Today I'm here with my most enthusiastic and excited Saturday morning co-host, Dr. Millicent Rovelo. How are you doing?
I mean, this is better than Saturday morning cartoons. I don't know what to tell you. I mean, I could have cartoons and Fruit Loops, or I could go to a podcast.
So wait, so you had Saturday morning cartoons? I thought that might have been like past your time.
No, I wasn't allowed to have TV as a child. That's why I'm so well read. But theoretically...
That's hilarious. We had, because we would watch like everything from the Jetsons to Josie and the Pussycats, and like it was a big event for Saturday morning when I was growing up. Well, instead we'll do a Saturday morning podcast about the midface.
Yes.
And this is a poorly understood operation, and I think that's why I wanted to do this, because I was listening to some lectures recently, and I just don't think people understand why the midface, the area from, as we said on a previous podcast, the middle of your face.
Wait. The midface is the middle of your face. Right. Okay, got it.
So it's basically the cheek and the area over the cheekbone, the zygoma, which I see how I did that.
For it. Yeah,
I wanted to preempt the
translation.
Exactly. So the cheekbone, this is called the zygomatic arch. This is the zygoma, the body of the zygoma, and then also it's what's called the submalar region here. Mm-hmm. So down below that area, that all needs to be elevated.
Right. So everything basically from the lower lid of your eyes to just below your cheekbones.
Yeah, maybe even to the nasolabial fold, the smile line.
Yeah.
But I will also add that there is a structure that runs through there that people complain about a fair amount called the nasojugal groove.
It sounds like it should be a lot sexier than it is.
It's not.
It's really not.
So where you see this, it's basically a line that goes from like the tear trough, from where where your eyelid ends, and it spreads over your cheek above the nasolabial fold lateral to it. So it's kind of going right through the middle of the cheek. And you see this a lot on babies when they're born. They have a very prominent nasojugal groove, but it does persist throughout life, and there are adults that are bothered by it, and oftentimes they'll tell you, I've gotten filler in there, I've had fat grafting, I've done all kinds of things to take care of the nasojugal groove. Have you seen this? Is it something?
Yeah, no, of course, everyone hates it, and it's a structure, which is why you can't just fill it and be done with it, because it's actually a ligament. It's a ligamentous, firm, fibrous structure that goes from your skin down to the bone. So it's literally like passing all through the layers of your face, and it's a very tethered point of your face that can be prominent just genetically at a young age, but typically becomes more prominent later in life as the soft tissues of the face start to descend.
Right, and so the nasojugal groove, you could also think about it almost like an inframammary fold. It's a condensation of fibrous tissue that exists right through the middle of your midface. Right. So when doing a midface lift, there's a lot of aesthetic considerations, and this is why I think this operation is so effective in making people look more, sort of more rested, more youthful, healthier. It just looks better. And by not just lifting it, but also by redistributing the volume of the midface, which can be done several ways. It can be done through a facelift incision, which is, sort of traditional. People kind of sneak over with their dissection under the skin, and then they do. There was Sherelle Aston had always pushed the FAME lift, the finger-assisted maloplasty, where he would actually kind of open up that area and release all those ligaments with a finger dissection, blunt dissection. There's the way that I like to do it is endoscopically from the incision up in the forehead, dissect down on the bones in a subperiosteal way, and then to break up the periosteum with either an Adson elevator or a Joseph elevator or one of the big endoscopic elevators, just break the periosteum up so that it spreads out, and then when we lift, we get a volumetric redistribution of that soft tissue that just looks awesome. And that's really what's going on in a midface lift. I don't know, like I do a lot of fat grafting with it too, because there are certain things near the surface that you can't really take care of. But, and I also typically do a lower lid blepharoplasty with it, because through that blepharoplasty incision, we can release the tear trough ligaments, the arcus marginalis, which is the ligament along the orbital rim. and get that redistribution, which shortens the lid, elevates the cheek, and just looks great.
There's your podcast, folks.
Okay.
Pretty much said everything you need to do for the midface.
Well, the reason I wanted to kind of get your feedback on it, because I know you've been kind of doing this also. What do you see as the challenges in sort of getting that done?
Well, I think one of the first challenges is starting with people just even understanding what's happening, because so many times people think that if they're coming in for a facelift, this is automatically going to be addressed because it's part of your face. And in a traditional facelift, it's not really. You do have to do separate procedures to address it and take care of it. So a typical just classic lower facelift is going to get the neck, the jowls, the jawline, but it's not really going to do a whole lot for the midface or the cheeks. So if that is something that is of concern, if that's something that your surgeon points out to you, just know that you're going to look at it probably additional separate procedure to do something for the midface. But the midface can also just be done as a standalone procedure. This is an area where you are going to see probably the earliest signs of facial aging. So it's not uncommon to see younger patients coming in, late 30s, 40s, to have this done because they're seeing the signs of aging. Their cheeks are falling down. They're not as high as they used to be. So I think that it can be a standalone procedure or it can be combined with a facelift, but it has to be addressed because otherwise people are going to think they're going to get something that maybe they won't. So I think just a basic knowledge and understanding of what it is like the most paramount.
Yeah, and just for the surgeons out there, I had a former fellow of ours call, say, I was trying to do this mid-facelift the way you do it, and I was down on the bone and getting the release of of all the soft tissue, and it wouldn't move. And he goes, I got some movement on it, and it wasn't awesome. I wasn't really thrilled with it, but I got some elevation. But you used to do it, and I'd see you really move the cheeks around. And it was because it wasn't a wide enough. After we talked, technically speaking, he just didn't get enough of the release of the soft tissue over the cheekbone, the zygoma, and then also down into the fibers of the masseter, which is the chewing muscles down under the zygoma, because you really do have to release it if you're going to get it to move.
Right.
Otherwise, you have a sort of a
it's okay.
B- procedure, which is okay, but like if you want to get an A, you need to really mobilize the tissues.
I mean, these tissues are very stuck. Like they have very, very thick retaining ligaments, and they don't want to move. So you really have to release them to get that nice lift and elevation that you're going for. And it works. I mean, it definitely works. People love it. So you just have to sort of know what you're looking for when you're asking for it.
So when you do this, because I know you've done a few of these where you've been pretty happy with them, are you using the Endotyne device, which I have no financial connection to that company or whatever, no disclosures to make, but the Endotyne device, or do you like to use sutures?
I do both. Depends on what they need. So we're talking about how we're keeping the soft tissues elevated. You can release them and then you pull them up, but then the question becomes how do you fix them in place and keep them from sliding back down? And there are really two classic ways of doing it. One is to use traditional sutures where you put some sutures into the deep soft tissue structures of the cheek and then elevate it and put it where you want it and tie it down as a suture. Or you can use the device that you were talking about, which is the Endotynes, which is a absorbable material, but it's kind of like a little tacky, I don't even know how you'd explain it.
They just have little prongs that go into the soft tissue.
Yeah, and they kind of just stick and you put it down and it stays where you put it. But those can be felt. So patients that have really thin skin, not great for the Endotynes. Yes, they dissolve, and yes, give it some time, but it takes like 6 to 9 months before they fully dissolve. And so it can be really annoying to patients with thin skin because they can feel it, you can kind of see the outlines of it. So those patients tend to do better with just a straight suture fixation.
And just for completeness, I have to mention threads because this is what these thread
I'm sorry, that was involuntary.
So the thread lifts are designed to try to do this operation with basically barbed threads that are passed through the soft tissue up to the temporalis muscle.
In an office setting.
In an office setting under local anesthesia, typically with maybe some sedation. And they work initially because what they're doing is they're elevating the soft tissue. But what they're not doing is releasing the soft tissues from the bone. So the mobilization is very temporary. Maybe it lasts 6 months, maybe 9 months. maybe longer. I don't know, but
that's about right. That's 6 months.
But I think because you're not releasing it, you're going to get some elevation, and then it's going to go away.
And then you do it again, and then all you're doing is creating a bunch of scar tissue in your face.
And then we complain about when we do a facelift.
So then when you come in for your facelift, we're like, gosh darn it, mother, stupid threads. It makes our job a little bit harder. And it's fine. Not everyone's ready for a facelift. I don't like the marketing that sells it as like a facelift alternative, because it's not. It's not a mid-face alternative. It's a temporary option that has its own set of issues and can create some issues with scarring and soft tissue.
Well, I really like the endoscopic mid-face lift. That's going to be my vote. If you come to me and say, I guess you go to a barber, you're going to get a haircut. You go to a surgeon, you're going to get an operation.
Totally.
That's the way it works.
It's like when I had the patient come to me and be like, so I have this lump that I want you to remove, but I don't want a scar. I was like,
okay.
So then why did you come to a surgeon?
So harsh language. How are we getting that out?
Go see like someone else that doesn't do surgery. But if you come to a surgeon, I'm going
That's what's going to happen.
I'm going to do a surgery on you.
That's what we do.
I don't know why you're acting so shocked over there.
So the threads, I think I just want to mention them because they kind of come up every now and again, and they definitely come up when we're doing facelifts and we're hauling those things out of the people's faces. So.
But I think we should talk a little bit about fat grafting to this area too, because sometimes you don't have to do all of this release of tissues and redraping. One option is to just do fat grafting to fill in those areas of contour deficiency and irregularity.
Yeah, I mean, I love fat grafting even in the setting of the operation, but you can do it as a standalone procedure. I find that patients who do that, who kind of needed the operation are somewhat like, I should have really done the whole deal, shouldn't I? Yeah. But, if you're not ready for it, 8, 10 cc's of fat, can do the job, and sometimes you need a little more, but, that's spread it out over the area, and people always like start to split hairs. Well, do you do structural fat or nano fat? So the difference being how much you disaggregate the fat into what size particles. And typically for this, I like structural fat.
Yeah.
Nano fat is more for surface issues where it's really very liquidy. It's you've really kind of disaggregated the fat down to almost a basically injectable liquid. But I do find that fat grafting helps a lot through here.
Yeah, it's another option. It avoids a bigger surgery, but it also has its limitations in terms of how much it can correct, and it doesn't always stick around or last as long, or it's not as guaranteed a result.
How much does a mid-face lift cost? And Beverly Hills versus the rest of the country, rest of the world. I mean, I know it's different, but...
It's different. So I will say that typically the mid-face is combined with something with the eyes. We should mention that.
Yes.
You mentioned briefly that you can combine it with a lower lid blepharoplasty, and that happens pretty commonly. If you have a little bit of extra skin or some fat that's pooching out on lower eyelids, the lower lid blepharoplasty is kind of needed to smooth that transition from the lower lid to the cheek, and you can release those ligaments through that incision. So not uncommon to do this with a lower lid blepharoplasty and a little bit of a brow lift. Yeah, exactly what you're doing. Because the incisions that you use for the mid-face are the exact same incisions that you would use to get the outside aspect of the brow lifted. And if you're experiencing mid-face descent, you're probably also experiencing brow descent. So it's sort of a combo package where you're doing a little bit of brow and then eye and then mid-face rejuvenation, because doing, I think, either or any of them just in isolation is not going to give you that wow result that you're looking for.
And you want facial harmony.
So if you're doing the brow and the lids and the mid-face as a unit, you're looking at anywhere between, I would say, $20,000 and $30,000 in Beverly Hills.
Yeah. I mean, I think it's probably a little more. I think the average in Beverly Hills is probably, if you're doing brow, eyes, mid-face, probably 35, I would say, somewhere in there.
The whole thing.
And it can definitely be more expensive. I mean, with me, I can tell you that my prices are higher than that. In general, mid-face lift costs anywhere from $45,000 to $65,000, depending, because I sort of do it as an upper facial rejuvenation. Yeah. And I think it's been as high as $75,000. I don't know, but, be prepared. Around the country, it's probably more in the $35,000, $40,000, $25,000 in some point. I don't know, but it's that kind of range. If you're doing it with the full face, then it can be anywhere. In Beverly Hills, it's probably $90,000 to $125,000. There are some people charging more than that, $150,000.
That sounds about right.
I'm in that range. But in the rest of the country, it might be $50,000, $60,000. It really depends on where you are. And also, this podcast is being done in February of 2025. So if you're listening to it in February of 2030, don't come in and be like, oh, we really want these prices. These were better. It's like, yes, that's
I'm sure
a
they
different
were. Yeah.
So yeah, anyway, that's sort of the story on the midface and the nasojugal groove. I think it's important. We have other podcasts that we've done in the past to listen to, but it's good information so that you know what you're kind of like looking at and thinking about when you're talking about these operations and people tell you this is what we're doing.
Yeah, I agree.
Cool. Well, in that case, I think this is the conclusion of the Midface podcast. So we are the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.